I hope we are all connected and you are able to watch my slides. Well, today's course is on my first implant. This is the very fundamental basic principle course where you're going to learn some basic principles of implantology. So implant dentistry is like a big pyramid of knowledge that you have to gain. And I just cannot have you fly to the top of it right away. So we have to take some baby steps. And what I'm going to do today is cover some fundamental principles of implant dentistry and take you through some of the first steps that you will take into implant dentistry. I'll give you a rundown of everything. So please be ready to keep a pen and paper handy. Write down the stuff that I'm telling you. There are a lot of numbers for today. So please make a note of every number that I bring to you and present to you. And I hope you enjoy the presentation. Most common causes of tooth loss are tooth decay. We have periodontal disease, failed endo, and root fracture. Once the tooth has been lost, we have to plan to place or replace that tooth with something. And implant is one of the options. But as soon as we see a patient and we start talking about the options, in our heads, this is what is going on, that it is a very, very complicated procedure, right? And we think that it is cumbersome, it is risky, and a lot of people, at least in the US and some other countries, are thinking, you know, I'm not going to get into a lawsuit, so I quit. And you feel that somebody is always watching you, right? Always is somebody watching you. There is definitely a high demand for implantology, and there is a predicted growth. The problem is that most people who are trying to get into implantology see the sign in front of them and say, oh, I'm not going to get into it. It's too difficult. Let's look at some trends that have come in the last few years. And this is a 15-year study where they found that the only prosthodontic procedure that has increased since 1992 is actually implant-supported restorations. And here's the breaking news for all of you, that implant dentistry is not a specialty. 80% of edentulous cases in general practice constitute of 3-unit bridges, right? And these are perfect cases for the first implant case. The success rate of implants is uncanny. I mean, it is just 97, 98% according to the literature. Dentists don't provide the services, and that is the problem. And the lack of patient awareness is another hurdle that we have to cross every single time we present a case to a patient. So what do we have to do? We have to first realize the potential ourselves. After that, we have to educate ourselves, build our confidence, educate our staff, patient literature in office, and financing option for the patients are required. These are some disclaimers that all the pictures that I'm going to show you today, all the cases I'm going to show you today have not been modified or photoshopped in any way or form. And neither myself or the Institute has any kind of a financial arrangement with the companies. So let's talk about the treatment that we typically recommend to our patients when they have pain or decay or tooth loss is endo. When you look at the success rate of endodontic treatment over a period of time, the success rate is really not that high, 74, 90, 92%. Retreatments and episectomies are worse than the initial treatments. And you can see that endodontic surgeries and retreat, the success rate may be as low as 36%. Success, when you compare endodontic treatment with implants, this is another thing that, you know, you look at the longevity and you look at the general success rate that you get with implants versus endodontic treatment. Prognostication of a tooth, it is very, very clear. Once you see if more than 50% bone loss that has occurred, please don't try to do periodontal treatment. Think about implantology as an option in these cases. Also, when we are doing crowns in a 3 to 30-year period, this study has indicated that almost 13% of these teeth will have to be restored in some way or the other later on. And of course, advanced periodontal disease is also one of the things that we take into account. Episectomies, on the other hand, the success rate is not as high as you would expect it to be. And therefore, I think it is our ethical and moral duty to give the patient an option for an implant instead of doing an episectomies. So just because we can save a tooth does not mean we should, okay? Think about implant dentistry when it comes to such scenarios. What do we need to consider in implant dentistry? Well, number one, we always start thinking about the prosthesis, which means the crown, the occlusion. And then after we have decided what kind of prosthesis we are going to place, now we start to work on the surgical aspect of it. Now we decide what kind of fixture, what kind of thread design we are going to use, what should be the connection type, what is the surrounding bone like. And then lastly, we look at the maintenance part of it. So our ultimate goal in implant dentistry is to be minimally invasive and be more efficient. Minimally invasive by doing less surgery, less trauma, less pain, less complication, and trying to be more efficient by employing techniques that are simpler, faster, give us better aesthetics, and preserve more of the tooth structure or the tissue. And out of all these things, I think the simpler, faster, and less morbidity should be on the top of our list at all times. Now, let's talk about the classification of implantology based upon the timing. So based upon timing, we have type 1, type 2, type 3, and type 4. Today, we'll be discussing the type 4, which is the late placement. So here is the basic difference between a tooth and an implant. And to highlight some of the most important thing is, number one, the tooth has a lot of connective tissue fibers, a lot of collagen. There are 13 different groups of fibers that attach to a tooth, provide nourishment, provide the blood supply to it. However, implant has got just two. It's got some parallel fibers and some circular fibers. So therefore, this is important to keep in mind when you're treatment planning, because you need to have a good amount of junctional epithelium. You have to have a good biologic width. You have to have a thick tissue to make sure that the connection between the tissue and the implant surface or the abutment is just as tight as it can be. Number two is vascularity. Because of all these reasons, we lose a lot of vascularity around the implant. You know, compared to the tooth, we have not too much of vascularity around the implant. And that is another one of the challenges in implant dentistry. And of course, you know, we have the connection type. The tooth has cementum and periodontium. However, implant is merely osseointegrated. So when we look at the different types of implants, you know, there are several different types, but what we focus on these days is the endosseous implants. And when you look at the implant designs or the number of implants that are available to us in today's date, we find that this is tremendous amount of, different designs that are available to us, more than 130 designs that are available to us. So when we look at a basic implant thread design, what does it consist of? Well, it consists of the threads, and the threads can be V thread, a square thread, buttress, reverse buttress, spiral thread. There can be a triple thread design. There could be a lot of different designs that have come up, but the basic ones are the V thread and the square thread. The V thread is an aggressive thread. Square thread is a little bit more passive. The second part of an implant is the surface itself. Now, when we look at historically from Brännemacher's time, he started with a machine surface, and now we're talking about rough surface. And how do we achieve this rough surface? Well, there are two ways. One is that we blast the implant with something and take something away from the implant surface. Number two is that we coat the implant with a certain type of a material. For example, HA coating or a TPS type of coating, you know. And just remember that, you know, the HA coating and TPS coating, the problem is that they often break, crack, and there are a lot of issues with it. But the idea is to create a rough surface, whether we are doing additive or subtractive procedures. And why are we doing this? Because we want bone to implant contact to increase. And this is dictated by cellular properties and the surface properties of the implant, including the loading protocol. So what are we doing these days? We are nowadays looking at implants that have a bioactive surface. What does it mean? Well, you are going to get much more predictable results with a active implant, bioactive implant, which has a surface and it has an interface. All these things you look into, so it's more biologically acceptable, resulting in rapidly achieved bony anchorage. And sorry, what happened here? I'm sorry, we're having some technical difficulties here. Presentation doesn't want to move forward. Okay. So now what you see is that the calcium phosphate coating that is present, what it does is basically forms a layer over the surface of the implant, and it precipitates a cellular activity around that implant. The other part is that the bioactive implant that we have now has a dome shape, which is very awesome to do sinus lift. So when you want to do a sinus bump or a little sinus lift, all you have to do is merely push the implant up, and the design of the implant would allow you to get a sinus lift. The next point is that we have to look at the thread design. Okay, the thread design in the bioactive alpha, the bioactive implant, the Alfa Gate implant, what we see is a V thread, which is very important to get primary stability. And we also see the combination of a square thread that is called a power thread, or helps us get primary stability, but also increases the surface area. But most importantly, what you see with the bioactive implant is that you start to see the blood creeping up as soon as it comes in contact with the blood. That means that you are going to get blood right away on the surface of the implant, and the entire surface of the implant is hydrated with blood that will begin the osseointegration process. And studies have clearly indicated that modifying the physical characteristics of the surface of the implant will result into stronger bonds and as compared to the modified implants. So here is an example, one of the competitors, and we tried these two implants, and we have tried this with several other implant companies. But what you notice is that the amount of blood that you see on the bioactive implant is far larger than the other competitors. Now, what is important with the bioactive implant also is that it comes in a very, very simple package. It's a very simple system, you know, and that is one of the most important things, that as general dentists and practitioners, you want to have simpler stuff, which is simpler for you and for your assistants. So when you look at this kit, you can literally put it in a palm of your hand, and you can see how simple, how straightforward this kit is. Okay. Now coming back to bone to implant contact, that is what we were talking about, the bioactive surface. What does it do? Well, cellular biology, surface properties, and loading protocols. So cellular biology is basically increased by increasing the amount of cell availability and blood supply, which should be present at the time when we do this. The surface properties of an implant is required to have some kind of a bioactive surface. And of course, your loading protocol has to be very, very prudent. You cannot load implants after 10, 12, 15 months and expect the same amount of bone to implant contact compared to if you had done that earlier. So now let's look at what happens, what is alveolar bone and what are the unique features of the alveolar bone. Well, alveolar bone is made up of 30% of organic material and 70% inorganic. The cortical bone has porosities of about 5 to 10%, and in trabecular bone you see about 75 to 95%. So what is the importance of having that organic bone? Well, more organic bone you have, it allows the ridge to expand. That means that you are able to extract teeth easily. We are able to expand the ridges with implantology. We are able to split the ridges easily. We can condense the bone. And this is all allowed because of the organic material present in the alveolar bone. And remember that there are marrow spaces that are present within the trabecular bone, ranging from 200 microns to 2000 microns. And sometimes they are really very, very large. So what we have to keep in mind is, because we are going through the cortical bone, which is mostly inorganic, the temperature control has to be maintained during the drilling process. So what does it mean? That it means that while drilling your implants, you have to take care of two things. Number one, that you should have a lot of saline irrigation compared to it, okay? And the other thing is that you can cool the saline. So what I tell my doctors to do is place the saline bag that you're going to use about an hour before into the refrigerator, and then take it out when the patient is in for the surgery. And because we know, and this is literature talking, this is not me, again, listen to this. It says the osteotomy for placement of osseointegrated implant has been indicated as one of the probable causes of early peri-implant bone loss due to creation of devitalized bone around the implant. And this devitalized zone is the result of interruption of blood supply and the heat generated during the osteotomy. So again, I'm having some interruptions. I apologize. There is some, for some reason, I'm not able to go forward with my presentation. So while I'm trying to figure this out, I know there was a question somewhere. Do we have the question here while I'm trying to figure this out? Why this is not working? So the question is that, that somebody says over here, I have heard that osseointegration is not the main issue with implants these days. They're very good. What is your take on this? Well, I can tell you osseointegration is just as important as the other factors. So, and I'll cover more as we go forward. So let's take a look at this. What happens when we place an implant into the bone? The implant surface comes in contact with the bone. And what you see over here is that you would expect in your mind that, everything should go fine. But what we forget is that there was drilling that was done. There was, as a result of the drilling, heat generation, there was a lot of trauma, and trauma will lead to inflammation. And that inflammation can lead to something called as a death zone. What is a death zone? Death zone is a zone around the implant that contains a lot of dead cells or necrotic cells. So it is very important that after we do our osteotomies, that we make sure that we do a saline rinse within the osteotomy to take out any pieces of necrotic bone that are remaining there. This other part of the study says that, a narrow zone of dead and dying osteocytes in the peri-implant bone are resulted as a result of the osteotomy. So now let's look at the cortical bone and the cancellous bone. The cortical bone is definitely thicker on the lingual than on the facial part. And the cancellous bone is, a combination of, 200 to 2000 microns wide spaces. And this can be either seen through the cone beams or through the X-ray, or when you go inside and start drilling, you will start to feel. So here are some examples of the different bone densities that you can see. And over here, you can see this bone density can, it depends a lot on the ethnicity, what they're eating, diet, a lot of different factors. But the other thing that you have to notice, sometimes within a same individual, this is a cone beam of an individual, and you see that on the right side of your screen, you have a lot of dense bone. However, on the left side of your screen, you notice that everything is hollow. There's a lot of cancellous bone there. So if you were to place an implant in the situation, good luck finding initial stability, So these are very subtle things that you have to keep in mind during the process of diagnosing and treatment planning your cases. So alveolar bone, talking about them, Mish has described them as 4 different types: type 1, type 2, type 3, and type 4. Type 1 being the cortical bone that you would typically find in the anterior mandible. Type 2 is in the posterior mandible and sometimes in the anterior maxilla. Type 3 is typically found in the anterior maxilla and posterior maxilla. And the type 4 is generally the posterior maxilla. And now we are also talking about a type 5, which is the softest bone we can see. So alveolar bone loss after implant placement, this is a great question. So alveolar bone loss also starts to happen after we place implants. And there are some good reasons to it. Number one is that bone resorption non-platform switched implants is usually about 1.5 to 2 millimeters compared to the ones that have platform switch. The other important factor is that if you have a thin biotype of tissue, that means that you have less than 2 millimeters of thickness of the tissue, you can expect 1.17 millimeters of bone loss around it. However, the thick biotype of tissue results in much lesser bone loss around the implant. And how about bone remodeling? This is again a natural process that will continue to happen. So as we know that implants can lose in the very first year up to 1.5 to 2 millimeters of bone around the implant, especially in terms of the vertical height, and therefore you see that concavity around the implant or the V-shaped defect that we see around the implants. However, the bone replacement or remodeling continues to happen over the period, the lifespan of the implant. So here we see some other reports have been published, and some people say that it is 3%, sometimes it says 7% in cortical bone, and then 24% in the cancellous bone. And this is probably one of the reasons why it takes so much time to eliminate the bisphosphonates that the patient is taking from the body. And as you know, it can take up to 10 years to eliminate bisphosphonates from the body. Now coming to the primary stability. In implant dentistry, primary stability and the secondary stability is one of the most important things. Primary stability is defined by stability in both horizontal and vertical direction. We typically measure it with torque when we are tapping the implants in. And a normal number that we try to attain during this process is about 35 Newton centimeters. So primary stability is attained at the time of placement. However, the secondary stability is after the first week of the implant placement until the healing is complete. So the primary stability depends on bone quality, bone volume, relationship between the drill and the implant diameter. This is very important when you go into the maxilla. Always remember, if you're drilling into a D3 type of bone, always undersize your osteotomy to make sure that you get good primary stability. Then you have the geometry of the implant, and the literature is very clear about it. It says the success of a dental implant depends on the stability of the implant and the quality of local bone, surgical skills, and the patient factors. Literature continues to say, recently, implant stability has shown to be a useful predictor and measurement parameter for osseointegration in both clinical and experimental studies. And I hope this answers the question that was asked to me before by one of the doctors here. Now let's look at this very important illustration or a graph by Raghavendra and Wood. When they published this paper, it is very important paper. So what it says is that initially the implant stability on day 1 could be at 100%, but as the weeks go by the time we get to the 4th week, the implant is the most unstable. So why is it so important to know this? Why? Because you should be telling your patients that, Mr. Jones, during the 4th week, I want you to be very, very careful. Don't put any pressure on that area. Try to stay away from hard foods, things like that, especially if you have an exposed abutment. If you have placed the implant subcrestal, then it is not of any consequence. However, if it is supracrestal, then you have to make the patient aware that this is the most unstable state. And then at about 6-week time, we start to see the stability peaking up back to normal. And from that point, it is a straight line right across. Now let's talk about the soft tissue. Soft tissue, my friends, is one of the biggest issue that we have with implant dentistry. And it has been so underspoken about. And let me tell you that most of you might be able to get a good primary stability. Everything might look good. And when you come back after 3, 5, 7 years, you start to see soft tissue recession. You start to see a thinning out of the soft tissue. That is a big problem. So pay attention to the soft tissue. How much of soft tissue, how much of keratinized tissue you should have? A minimum of 1.5 to 2 millimeters around the implant. If you don't have keratinized tissue, then one of your goal is to establish that keratinized tissue during the surgery. Biologic width, just like we have the biologic width around the tooth, we have the biologic width around the implants as well, and that has to be taken care of. Remember, the tooth has periodontal ligament, the cementum, and this is the secret of maintaining functionality in the tooth. However, the implant doesn't have periodontal ligaments or cementum, all right? And therefore, there is lack of blood supply, lack of tissue attachment, and this leads to degradation of the peri-implant tissue, which makes it very difficult to maintain tissue integration. There seems to be a question here, and the question is, what is the maximum vertical keratinized tissue that can be established? Well, it all depends, my friend. You can establish via grafting. Yes, you can establish up to 4 or 5 millimeters of keratinized tissue height very easily. So when we look at some of the other studies by Nozawa, who talks about the ideal thickness to be about 3 millimeters, soft tissue thickness 2 millimeters by Salama, a facial bone thickness by Grunder and Spray about 2 millimeters or more. These are important numbers. So keep in mind when you plan your cases and when you treat your cases that all these factors are taken into account. Now, how about the thickness of the gingiva and the palatal tissue? Well, the gingival thickness ranges from 0.53 and an average is about 1.56. The palatal tissue thickness varies from 2 to 4 millimeters and a mean average of about 2.8. And one of the best location to harvest connective tissue for grafting or increasing, like the question was asked regarding the keratinized tissue, you can use the premolar region or the tuberosity, which is by far one of the best areas to harvest tissue for soft tissue grafting or increasing the amount of keratinized tissue. Now, risk factors of soft tissue recession, what are they? Well, with implantology, it's mainly inadequate keratinized tissue to start off with, implant position. So if you place the implant too far facial, you are going to encounter recession. Then what kind of treatment have you done on cases? Immediate implant placement is a little bit more sensitive procedure than delayed placement. And of course, the biotype plays an important role. the thin biotype will always lead to a recession. So keep in mind that one of your goals with a thin biotype should be to, at some point, address that issue before you start to restore that implant. Now let's talk very briefly about anatomy. An anatomical structure in the maxilla are the maxillary sinus, floor of nasal cavity, incisive foramen, greater palatine vessels, frenums, and in the mandible, we have the submandibular fossa. This often interferes with the placement of the implant, and therefore we sometimes have to incline our implants lingually to make sure that we don't, pass through that, that into the mandibular fossa. Also keep in mind the other anatomical structures. Blood vessels, we know about the facial artery. I hope none of you in the initial stages are going to go anywhere near it. Maxillary artery, which is a branch of the inferior alveolar. Sorry, what am I saying? Inferior, actually, external carotid artery. I'm sorry. That is an important. What is very important is the lingual artery that sometimes all of us kind of ignore. Yes, it is usually placed more medially towards the tongue, but you will see the literature talks about the proximity of the lingual artery to the lingual border of the mandible in about 5 to 7% of the cases. So just be aware of it. It's not such a big threat, but just be aware that you might encounter the lingual artery. The other important part is a lot of times my colleagues are trying to do an inferior alveolar block and the patient is still in pain. What we have to keep in mind that sometimes we miss the mylohyoid nerve. Okay, so you have to, while you're anesthetizing the inferior alveolar nerve, make sure sometimes the mylohyoid remains unanesthetized. So you have to anesthetize this as well. And finally, one of the most feared nerve is the lingual nerve, just because of the proximity of it to the mandible. And remember, if you are working in a second molar area and you're trying to reflect a full thickness flap or a flap around the third molar area, about 15%, 14 to 15% of the time, you will find the lingual nerve resting on the crest. So just be careful when you reflect these flaps. Other anatomical anomalies and variations are just tremendous. You can see from these slides that the anatomical variation is tremendous. You look at the inferior alveolar canal, sometimes you see 2, 3, 4 different branches of the inferior alveolar canal. And you have to be very, very careful about, this is just a part of your diagnosis and treatment planning. And sometimes we take, PAs just to see where our implants are, where the bone levels are. So keep these two things in mind. Bone level assessment using an X-ray with a palating technique has a precision of right about 0.5 millimeters, which is pretty accurate. But if the film holder is inclined by about a degree, you can get an error of about 0.17 millimeters. So keep that in mind. Now let's start with treatment planning. Well, as a part of the treatment planning process, you're going to take the medical history, you're going to take the dental history, you're going to do a thorough intraoral exam, radiographs, study models, cone beams, jaw relation. And of course, there are some relative contraindications like smoking, bleeding disorders. Remember, age is not a factor. So you can be placing implants on a healthy individual who is 82 or 89. It doesn't matter. There are only 2 absolute contraindications, Paget's disease and fibrous dysplasia. And let me tell you, we can still place implants in cases with Paget's and fibrous, but at this point in initial stages of your career with implantology, I would recommend not to take up these cases. Some other pre-surgical considerations are as follows. Keep a close eye on the platelets. If platelets are less than 25,000, you can expect spontaneous bleeding. So anytime you see the platelet count under 60,000, please do not do a surgical implantology on these patients. Antibiotics are really not required. They are mainly meant for treating infections. But however, the literature does talk about and suggests giving 2 grams of prophylactic amoxicillin an hour before placing the implants. You would also see this very nice article, a meta-analysis that was published years ago, and it talks about 78% lower risk of implant failure when you take antibiotics. So now when you have a patient sitting in the chair, you're going to do a physical examination. And the first thing that you look at is the arch shape. What is the size? What is the occlusion like? Is the patient good with maximum intercuspation? Is there a good anterior guidance present? Because all these things will affect the prosthesis on the implant. If you see a tapered arch, and if you're doing a full mouth rehab, ensure that you increase the number of implants and put some more anteriorly as well. However, with the square implant, you can spread the implants further apart. The general signs of wear are a concern, but they are not such a big deal. The inter-arch relationship, as a rule of thumb, if you are trying to restore teeth supported by implants in the posterior area, you need at a minimum of 7 millimeters of space. For anteriors, you need 8 to 10. And for removable prostheses, you need more to compensate for the thickness of the acrylic and the plastic that you will have. But keep in mind, the question you have to answer. So let's say not all the time do I get 7 millimeters in the posterior area. Sometimes I'm dealing with supraerupted teeth. Yes, I can do a crown and gain some space. But whenever you have less than 4 to 5 millimeters of occlusal space available for the restoration, always do screw retained restoration and don't plan anything with cement retained. So here we have the visual examination. On visual examination, what do you see immediately? You see a dehiscence, you see a high frenum attachment. We are looking at the space. And if you see cases like this in the mandible, be very careful treating these. These are not the cases that you want to venture into for the very first time doing your first implant. All right. You should have some tools that are required. Here we have a Williams probe, 15 millimeter Williams probe that can be utilized to measure the distance, measure the space that we have, the thickness, arch length, so on and so forth. And we have to able to recognize certain bony defects. Some of the common bony defects are dehiscences and fenestrations. So a dehiscence is when you have loss of crestal bone and it extends along the long axis of the tooth surface. However, fenestration is merely a window, a small opening in the tooth, which could be naturally present, especially around the canine eminences. You can see, the root eminences of canine. You will often find fenestration. And the literature, especially with immediate placement implants, keep in mind that literature is very clear on the fact that you will find fenestration in 6 anterior teeth most of the time. That means almost about 80 to 90% of the time, you can find fenestrations on the facial aspect. Now, everybody talks about surgical guides, so I'm going to give you a quick review of surgical guides. Why are we using surgical guides? Well, the number one reason is so that we don't get cases like this. What can we do in office? Well, we can do a suck down. We can use, light cured resins like Rebotec, and we can make a nice trays. We can also do an Essex type of surgical guides that are easy to fabricate in office. And then you have these pin retained full mouth, which is tissue supported as well as bone supported that are available. Alfa Gate actually has a surgical guide, which is pretty neat. They have a surgical kit. They have the new version 2.0 these days. And what it comes with is a step drill. Step drill is important to do drilling process and engage the drill even before you start the drilling process into the initial osteotomy that you have drilled into. So a two-step drill helps a lot in engaging into the bone, getting about 2 or 3 millimeters into the bone before you start the drilling process. You will also notice that there's a flat surface on one surface area. So when you place these drills through the guide, one of the important problems or issues that we have with guides is that there is no place for the irrigation to get through. So over here, you can see the way the guides are made. There are small little openings along the flat surfaces of the drills, which allow for the irrigation solution to get into the site and give us the proper cooling that is needed. Alpha Guide also allows you to have they are going to send you a very detailed description of step by step what you're going to use. So here, based upon what I have received, these are the drills that I will be using. And it gives you an entire analysis of what the anatomy looks like, what does the soft tissue height look like, where the prosthesis will end up, what is the bone density, so on and so forth. So there's a lot of information. So if you are interested in doing your first implants with Alpha Guide, that would be a great idea. If not, you can do something in office and you can take a model, you can plan the cases, and I'll show you some planning today in a while. So now we have placement in the maxilla. Very often, if we are doing freehand surgery without the guide, there's a tendency for people to go in at about 90 degrees to the crestal bone. Please don't do that, because you are going to come out of the facial aspect or the facial concavity of the maxilla. So please try to give about 5 to 10 degree taper, and that is the direction that you should be drilling into. The other problem is when you look at a ridge that is very thin ridge. It is very difficult to stabilize the surgical guides. So all we do is get some indentation and then we go freehand. Again, you see over here, we did the indentation with the surgical guide. And from here on, I take, because the bone is thin, I want to expand and push that organic material and expand it. What I'm doing is a slow revolution osteotomy at 50 RPMs without water. And then we place our implants. So if you see a microfracture like this, don't be concerned too much about it, okay? This is just a hairline fracture, not such a big deal. If it was a compound fracture, then you would utilize that piece of bone as a graft material and will not leave it attached or remain over there as a compound fracture. Now you will ask me that why are we talking about non-surgical guides or non-guided surgical procedures when we have all these surgical guides that are available? So here's the news for all of you. Computer technology. This is an article, a meta-analysis that clearly showed that there was a mean error of 1.12 and 1.39 in two different axes, X, Y, and Z. So be very careful when you use these. And in this analysis, they said that tooth and mucosa support guides seem to have a better accuracy compared to the bone support guides. There was another consensus at the ITI that clearly said there is no evidence yet to suggest that computer-assisted surgeries is superior to conventional procedures. So you see that least traumatic osteotomy, condensing bone for primary stability, a self-tapping thread design, and a bioactive surface, these all can give us a great result. Remember that friction causes heat, so keep your revolutions under 800 RPM with copious amount of saline, all right? And again, remember this article, that narrow zone of dead and dying osteocytes in the peri-implant bone will remain there. So these are some of the key factors that will help us achieve predictable results. Now let's look at some practical aspects. So these are 3 rules that I make for my students. Rule number 1 is that mesiodistally, when you're measuring, whatever size of implant you choose or whatever distance you have, you should have a minimum of 1.5 millimeters available on each side. Rule number 2, you should have about 3 millimeters if you're placing 2 implants side by side, and you should have 2 millimeters on the facial and 1 millimeter on the lingual available when you place your implants to get better results. So let's see how we plan our cases. So here we have a model. If we are planning a posterior tooth, take the central fossas of course, the teeth have to be well aligned in the arch. Remember that, okay? This is only if the teeth are well aligned within the arch. So we place an implant here. We use cingulum in the posterior areas as a reference point. And then we use our numbers, okay? Then we use our numbers. And again, remember, what are we doing? We are trying to get a proper prosthesis. So here's an example. I'm going to plan this case. So let's say, according to the numbers I have told you, 1.5, 3 millimeters, and 3 millimeters, if I follow those numbers strictly, this is what I achieve, okay? Now let's see what happens when I do the prosthesis. This is where my prosthesis goes. This is absolutely wrong. So what is happening here? Why are these numbers incorrect? Well, this is the minimum value. So when you look at the actual distances, so the osteotomies are not dictated by any numbers, but by the anatomy of the tooth, the length of the tooth, mesiodistally, and the buccolingual width that you're trying to achieve. That is what dictates where the implants are going to go. So therefore, the correct placement of these implants is going to be here. Again, remember, these numbers 1.5 and 3 are just the minimum that you should have. They are not written in stone that you have to follow them. The other thing that is you have to keep in mind when you are doing a single edentulous case is you have one tooth in the posterior and one in the mesial side. Remember that the mesial side has an inclination and the distal side one doesn't. So which one do you follow? Are you going to follow the tooth in the posterior or in the anterior? So this is what happens. Well, what you should be doing is you should be going parallel to that mesial tooth and not the distal tooth. Why? Because if you try to go parallel to the distal tooth, you are probably going to end up being here and you will injure the root surface of the adjacent tooth. So this is another important point that you have to keep in mind while you're doing. If you ever want to create some references, it's a good idea to use the cusp heights of these teeth as a reference, and then draw a line with a pencil, and then use these pencil lines as references. The other part is that you should remember that when you're placing these implants, the hex, the flat end of the hex, has to be facing the facial, okay? It should not be like this. The pointy part of the hexagon should not be pointing on the facial. This will result into midfacial recession of the bone. Okay, so I'm going to do a very quick demonstration. So I'm going to exit out of this place. We have a question. And apparently there's a question there also. Is there a question? Yes. Yeah. The question is, when placing an implant. So the question is, when placing an implant, if accidental fenestration is created, would you remove the implant and wait for healing or to be prepared graft material? Well, my dear friend, you will very soon see something that is pretty cool. I'm going to show you, okay? So we have the models here, and hope all of you are able to see what I'm going to show you now. I'm sorry, I don't have the gloves here, but you can see. So let's take a look at this kit here, okay? Look at this kit. Such a small kit, you can actually hold it in the palm of your hand, and you can see what it is. Over here, there's a pilot drill. This is a very unique pilot drill, okay? You won't find it in a lot of kits. You see this drill right here? It is such a great drill to start your osteotomy with, okay? So this is what I'm going to use. I'm going to start my drilling process with this drill over here. Yeah, that's okay. And here you can see the first drilling protocol is with the pilot hole, you create an indentation very quickly. You come off, and then you start with the 2.0 drill. And remember, the way you are holding this is very important. You see, we have to go along the straight line, in and out, just two ways. So you should not spend more than 2 seconds in the osteotomy. You go in and out. And remember, when you're doing implantology, a lot of clinicians, what I see them doing is they do this. You know, when they do this, what is happening? They're changing the direction. In implantology, you move this hand as a whole. Okay, you do a bodily movement up and down. Okay, like you do with your rotary endos, you go 1 back, 2 back, 3 back. That's how you should be doing. And you see that you can collect a lot of shavings from here. Now, what is cool about this kit also is, like I told you, this is a step drill. So if you see, what happens is that if you don't have a step drill and you put the drill on this osteotomy, it is not engaging in the osteotomy itself, but you will notice that this drill actually engages in the osteotomy right here. Okay, you see, it goes in by about 2-3 millimeters, and now you know that you are stable. So now you can start your osteotomy again. 1 back, 2 back, 3 back. Okay, and we take out these things. So now we are at a 2.8. Then we can go with the next one, 3.2, and again the same principle. You see this? It goes in very easily, and now it stays in place. It will not allow you to go anywhere further than this. And once we have done this, this is the Alfa Gate implant, the bioactive. This one actually is a demo, so this is not a bioactive implant actually, but this is just for demo purposes. So can you open this, please? So the other thing is that there's a palating pin here. You can put the palating pin at this point if you want to check for your angulation. Okay, make sure the angulation is correct. It is vertically straight, a straight line. See that? Okay, and then if you want to tap the implant, the Alfa Gate implant comes in a little while. And just so that you know, I'm pretty sure Dr. Zahalka will tell you that, you know, they're coming up with a new design, which is very, very beautiful design. So all you do is you place the implant here, you torque it in with your hand, okay? That generates very less amount of heat. And then you have the torque wrench, and you can take the torque wrench and you can slowly start to tap the implant in all the way down, okay? Now, let's say if you want to use the motorized version, it has both motorized version as well as the hand torque ones. I'm using the hand torque one because it generates less amount of heat, okay? And then when you are halfway, you can actually remove this. This is the mount, and it has a screw right here, okay? It has a screw right here. This is the cover screw, okay? So this is the cover screw. You can take the cover screw off, and you can place it on the implant, okay? This is in here, and I have left this sticking out so that I want to show you the connection between the screw and there. It is totally flush. And with the flush, it also leaves behind a small area, about 0.5 millimeters of area, which is for platform switch and growth of the bone in this in the site. So this is how the drilling protocol is typically done. All right. So now let me get back to the presentation really quick. Are you guys able to see? No, you're still not able to see. Trying to share the screen here. Okay, share screen again. Okay. So now let's take a quick look at some cases. The first thing that you do is, if you're not using a guide, you will take a lead pencil, a sterile lead pencil, and you will mark the area and you will create a crosshair on that site. Then you will make your osteotomy initially at 800 RPMs, and you will put this paralleling pin and make sure that it is parallel to the tooth anterior, the mesial tooth, okay? And then you take a radiograph, and after you are happy with the radiograph, then you ask the patient to bite down. And you can see that the paralleling pin is in contact with the largest cusp, opposing cusp, which is the mesiolingual cusp. And the pin represents the central fossa of our restoration. So you can see that the central fossa will coincide with the, or occlude with the mesiolingual cusp of the anterior of the upper tooth. We look at the parallelism, we are pretty good over there. This is implant placed all the way in. Here again, you can see another angle from another angle. This is at the crest. You can see we have 2 millimeters of bone on the facial, 1 millimeter bone on the lingual, and here is a proper closure that we have used with the simple interrupted sutures. After you have placed the implant, a good idea is to simulate placing a tooth. And you see we have nice embrasure spaces, we have nice contours, we are right in the center, so everything will look great with this restoration. Case number 2, we are placing an implant on the lower right. This is what it looks like. We give a crestal incision, reflect a full thickness flap, mark our osteotomy site, and we are done with the final drilling. And you can see that blood, that is so important. If you don't see blood in the osteotomy, my friends, don't place an implant. You'll be making the biggest mistake, okay? Don't place an implant if you don't see blood clot coming or blood coming into the osteotomy. That is very important. And you have to make sure that you have 2 millimeters of bone on the facial, 1 millimeter of bone on the palatal side, okay? And this is where this implant has been placed. And you'll be wondering, what is this micro gap? And I will show you what is the importance of this micro gap and why I do this all the time. The Alfa Gate design allows me to get this thing because it narrows out at the crest, leaving behind this small little space that is such an important space biologically that most people who don't pay attention to biology, don't think that this is an important case, but I'll show you some studies. So here we have placed the implant, the tooth goes on, and now you can see again, I can simulate an embrasure space for the papilla regeneration, and also the embrasure space for which will act as a food spell. In this case, we want to get a tension-free closure. So what we do is we put in a horizontal mattress and followed by an interrupted suture. Sutures have to be removed only after 3 to 4 weeks. Do not remove them earlier than 15 days. Why? Just not because I'm telling you, because there's a scientific reason, there's a biologic reason for it, okay? You have these silk sutures, okay? These are vicryl. This is vicryl after 7 days. This is silk after 14 days. This is horrible. This will ruin everything around what you have done. So please try not to use silk sutures, all right? Try to use monofilament sutures that are clean, neat, and tidy. Bacteria doesn't cling onto it. It's so easy to manage. And here I'm showing you the difference. Look at the difference between the monofilament and this. And you tell me, you be the judge. Which one would you rather have? The one on the bottom half of the screen or on the top half of the screen? Which one is more biologically acceptable to you? So why are we waiting such a long time? Because the time for the flap to bound down takes at least 2 weeks. Okay, biologically, it takes 2 weeks for the periosteum to bound down to the bone again. And therefore, try to leave the sutures in place for a minimum of 15 to 20 days. Now let's look at this case. Here we have a case. It seems like there's a dehiscence on the facial. We reflect the flap, and you can see this is a full thickness flap. This is how your bone should look like. There should be no remnants, no torn periosteum anywhere. Okay. Now, when you look at this and you look at it from this angle, you think to yourself, "Oh my God, he's too far lingual. This is horrible." Okay. Not all the time, my friends. Look what I'm going to show you. Wait and watch. This is my osteotomy. I've got 2 millimeters of bone on the facial. I've got about 2 millimeters of bone on the palatal, on the lingual. If you look at the midline of the central fossa of the molar, don't look at that restoration because that's a porcelain crown. Lab did a horrible job with that. Okay. So these challenges or certain scenarios you will come across. So make sure that you are where you want to be in relationship to that ridge. Again, look at that blood. Look at that blood coming through the osteotomy. That's a good sign. Now you take your bioactive implant and you place it. Okay, you place it all the way and look at that micro gap. And what happens in that micro gap? Look at that blood oozing in. More blood oozing in. Just wait for a few seconds and you see more and more blood coming in. That's a good sign, let me tell you. And I will show you why. So look at this again. We have the micro gap around the implant. That's roughly about 0.5 to 0.8 millimeters in this case. And you see that there is a platform switch with a cover screw on. And if you leave this for a while, within a few seconds, you start to see blood pooling in. Now, what do? You ask your assistant to take the blood off? No, let it be there. Leave it alone. Okay, leave it alone and see what happens. Because we are trying to cover this platform, this prosthetic platform. I want the bone to grow over this platform. All right. The more bone we have, the better papilla will be able to regenerate. Okay. And so this gap will allow for new bone formation rather than remodeled bone formation. Here we have sutured it atraumatically. You can see the horizontal matter suture right over the implant. And then we have done the other. So this is the literature that when you try to torque your implant and try to get the primary stability from the crestal bone at about 50 Newton centimeters of torque, you are going to fracture the bone. However, if you leave a little space around that crestal bone, with zero torque, what you will get is new bone formation, according to this article. And new bone formation is better because the resorption will be almost negligible. If you have remodeled bone, you can expect more bone resorption around the crest. Now let's look at this other case. A full thickness flap, nicely reflected. This is called the envelope flap. Look at the nice clean bone. Here is the osteotomy, and you can see the blood pooling in. Here is my implant. And look at this other case. And we have the similar situation like we had in the other case. So now, is this good? Let's check it. Let's check it out from a different angle. And the second slide I have put up is from the previous case. They look almost identical, right? They look both identical, but they are really not. So let's look from the other side. This is how it looked on the other case where we were right in the center. However, in this case, my dear friends, we are too far lingual. You see that? We are too far lingual. So one of you had asked me a question that if there was an osteotomy that was miscalculated and you had prepped it, should we graft it? And the answer is no, you don't graft. So this is what you do. You move your osteotomy more facially, okay? Try to be in the center, okay? And what do you see? You go slow. After the initial osteotomy, after the pilot drill, I want you to go very, very slowly at 50 Newton centimeters. And what you're going to see is that bone, autogenous bone collecting right at that spot right here. Okay. You will see the autogenous bone collecting right in this area right here. You see that? That's the autogenous bone. That is what you want. You don't want any garbage from outside. That is what you want. So now once you have done that, here we have placed the implant. We see the blood oozing out, which is exactly what we want to do. And here we have a closure. Then we come back exactly 6 weeks later. I call the patient back and look at the amount of bone that we have. And let me take you back. Let me take you back to the point and see the blood. You see where the blood is over here? You see where the blood is, right? Wherever the blood is, that is exactly where the bone formation has taken place. Look at this. You want to see from other angle? Look at this. You see, blood coming from bone will result in bone formation, provided we have been able to stabilize it as a clot or as a blood that will not move during the healing process. So now I have a good problem in front of me. Now I have more bone than what I actually need. So now I have to take a burr to take away that extra bone so I can get access to my implant. So look at this. Here I have access to my implant. I have taken a slow speed Brasseler number 8 burr, and I have cleaned out all the bone around it and made place for my abutment to go in. Here is my standard abutment from Alfa Gate in place all the way down, make sure. And now I can secure it with a gut suture, because now it is not really that important. So in the interest of using and showing you this presentation, I was in a little bit of a rush. So I called the patient a week later to show you exactly what will happen. And so here we are. The tissue is still healing. We take out the healing abutment and we put our impression post in, and we take an implant level impression with this Alfa Gate post. This is an open tray. Here you can see my implant is right in the center, right? Initially you saw it, it was more lingually placed. And here's the final restoration. I'm sorry, I just placed this morning, so I didn't have the time to get the pictures and put it on the slide presentation, but it came out really nice. There's another case, mid-crestal incision, reflect the flap. Here is the osteotomy. Now, some of you might say, this is too far palatal. No, it is not, my dear friends. Let me show you why. Because we are following the cingulum and the central fossa of the adjacent tooth. And this line almost bisects the implant, but not only for that reason. Remember, we are supposed to have an emergence profile of a tooth. We are not just supposed to be thinking about implants and bone. We should be thinking in our mind about a tooth that is going to go in there. All right. So here we have, if you imagine that you place an abutment will hold the space, and then the lab will make you a crown that will hold this space. Now, when you look at the lingual margin of this area of the space right here, when you look at this lingual margin, this coincides with the cingulum and matches the bicuspid right here, the cusp of the bicuspid. So that is why you're supposed to get implant placement in anterior is very, very critical. Here is the suture. And when you have, oh, there seems to be a question. Okay, what's the question, dear? Why do we submerge implants if 6 weeks later you will place a healing abutment? Why don't you place the healing abutment in 1 day? Yes, you can place a healing abutment in 1 day. There's no, this is something that I'm doing an Alfa Gate study, and this is just a beginner's course. So I'm showing you stuff that most people starting out with implantology are going to use, okay? But yes, you can leave a healing abutment. You can close it with a healing abutment right at the time, provided you have achieved about 40 to 45 Newton centimeters of torque, and also measure your ISQs. So let's talk about extraction socket. What happens in an extraction socket? Extraction sockets, the tissue, the soft tissue starts to go down about 1/3 of the way. Then what we see is that the blood from within the socket starts to fill in that space. And you get a blood clot act as a scaffold, and over the next 4 to 5 months, you get a delayed healing. But do you see how the healing take place? It took place at about a 45-degree angle. So now when you place your implant, and if you thought that the crestal bone was always flat, good luck. Why? Because you're going to see some threads showing. So what do we do with these threads? You can either graft it, or you take a shorter implant and place a shorter implant, wherein you will see a little bit of lingual plate. That will you will be about 2 to 3 millimeters subcrestal from the lingual plate, or you can use or you can use the same implant size and you can push it further down by about 1 millimeter. And this happens. So this is an article published by Arujo and Linde, and they measured this. They said by about 4 weeks of time, there is a steep decline in the facial bone height. And on an average, this goes down by about 2.3 millimeters. So keep that in mind. This is my last case I want to show you very quickly. And watch this case. This is a bridge, implant-supported bridge. Look at the soft tissue thickness. This is a thick biotype, very ideal for people who are just starting out implantology. Now, some of my colleagues would say, hey, what about the recession? What are you going to do with it? Well, this patient has been with this recession for almost 15 years, and I'm not going to fight him to get new crowns or things like that till the time I see no signs of decay. But keep this in mind, how much of root exposure is present in this case. All right. Here we make our surgical guides. This is what my assistants would do. They will take the acrylic teeth, they'll put it on a model. We'll do a sucked out tray, full thickness flap reflection. This is freehand surgery after the initial guide was placed. And here we are at the restoration. Now you see that blanching. That blanching should not remain for more than a minute. If it stays, there's a problem. Remove the abutment, give an incision, relieve some tissue, because there's no elasticity in the oral mucosa. Remember that. So this is what we saw at the time when I placed the abutment, and this is exactly about 20 seconds later. I start to see that the blanching is starting to disappear. Here we are, the restoration in place on the day off. Looks okay. There's some remnant cement. Not such a big deal. It'll come off. This is 1 year post-op. And what do you see here? There's lack of papilla. Now, if this was an aesthetic zone, I don't think our patients would say, Doc, it is okay. I'm okay with that. No, they will not be okay with it. But whose fault is this? Is it your fault or is it the lab's fault? Well, in this case, it was both our fault. I did not pay much attention to it initially, and the lab obviously had no idea what the hell they were doing, right? So what they did was they created and filled out that space that actually belongs to the papilla. So let me show you. This is 11-year post-op. This is 11-year post-op. You start to see how the soft tissue has come around this. This is okay. But wouldn't it be nice if we had a papilla right about here, okay? And we had nice contours, right? This would have been very nice. But we didn't pay attention. The patient didn't care much about it because it was the posterior teeth. I wanted to do something good, and I told the patient initially, I said, I don't like, you will not have the papilla. And he said, you know, Doc, don't bother about it. I'm able to eat, I'm happy, but I just want to let you know that this is a problem. So make sure that you leave some space between your restorations, which would allow the papilla growth into that area. All right. And one of the last thing, there's another question, I believe. What does it say? The question is, do I still do cement retained restoration? Yes, my friend, I still do cement retained restorations. I love doing them. There are times I'm doing telescopic copings over my multiple implants, and I do cement retained restorations. So now let's, I'll cover this last topic that I have to cover, and then we'll be done. I was given about an hour and a half, and I need to give you 15 minutes for question and answers. So I'll wrap this up really quick. Shoulder implants. Here's the case. When the case comes to you, we have an option, okay? We have an option of doing tilted implants, or we have the option of using shoulder implants. The question is, as a clinician, this is your choice what you want to do. If I was a clinician, this is what I would do. I would place the shoulder implants instead of doing longer tilted implants where the prognosis may be questionable at times. And you can see the success rate of shoulder implants is just as good as the larger implants. The literature is very clear on this. You look at this study and it says the survival rate of short implants in partially edentulous patients is similar to that of standard implant with 2-year survival rates, right? Let's look at another study. This is a meta-analysis, by the way. This is the highest amount of scientific evidence we can achieve. And it says that with the exception of maxillary anterior teeth, rough surface implants with a minimum length of 7 millimeters presents with no additional risk of failures within the first year. Then we had this other study that was done. Over 2,000 implants were placed with a survival rate of 98 and 99%. So remember, shoulder implants do have some value, but you have to be careful when you're using shoulder implants, all right? Because they can present some greater risk. So increasing the width may be a good idea. So if you're placing or choosing a 6 millimeter implant, maybe you want to increase the width, because with every millimeter, you will get 30% more surface area for osseointegration, okay? According to the science. So in conclusion, remember what I told you in the beginning. What is our ultimate goal in implantology? It is to be minimally invasive by doing less surgery, less trauma, less pain, and causing less morbidity to our patients, and being more efficient by using simpler, faster techniques that will get us better aesthetics, more preservation of soft tissue and bone, and we can get better functionality. And remember, there are a lot of factors that will affect our outcomes. There are patient-related factors, there are site-related factors, and there are technique-related factors. And all these factors have to be taken into account. Patient-related, like systemic health, smoking, oral hygiene. Site-related are the extent and orientation of the defect, soft tissue thickness, we spoke about it, the vestibular depth. So what is the ideal vestibular depth? 4 millimeters is the minimum that you need in the vestibule to place an implant. Then we have incision designs. What are you doing? How good you are at doing this? Educating yourself is important, but take courses that are more scientifically based rather than going to a company-sponsored program. Continuing education is important, and you have to take it in an order. Don't take some random courses here and there. Otherwise, you're going to get random knowledge. You will not have a full, a proper education. You will miss a lot of important information, and you may end up with results like this or like this. Okay, so don't do that. Learn how to suture. I'm sorry I didn't have enough time to cover suturing, but suturing is one of the most important things that we do in implantology. So spend a lot of time suturing. Eliminate the dead spaces, especially when you're opening up larger flaps. Dead space is a big problem, and you should know how to recognize it and eliminate it. Otherwise, you're going to get patients with a lot of hematoma, pain, swelling after the fact. So what are some of the keys to success? Well, you have to maximize the number of implants, minimize the diameter and length. Try to put no pontics or no cantilevers initially. Now, once you get really good at doing implants, then you can do all these things. You can do cantilevers, you can attach implants to the natural teeth, you can splint crowns, and try to give patients an implant protected occlusion, especially patients who are have factors that we have to keep in mind. And therefore, the success begins at the edge of your comfort zone. We have 2 questions. All right. And you have to push yourself beyond your comfort zone in order to get to a point where you feel more comfortable. And remember, simplicity is the key. All right. The more simple techniques you adopt, more simplistic you keep your life with simple techniques, simple procedures, simple kits that you get from these beautiful companies that are making such innovative implants like Alfa Gate. You are going to be very, very lucky. I remember myself struggling with kits in the late 90s and early 2000s. We didn't have these simple kits. So make sure that you find simplicity. And remember, whatever you do, always try to look at the evidence-based information. Try to establish a practice that is more based upon research and studies, not just based upon somebody telling you something and you're just doing it randomly. All right. And this is my request to all my audience at this point, that please, please, please think biologically first. Okay. And even a carpenter can place implants into these jaw bones and these peg jaws and all these things. But it takes a scientist, it takes a doctor like you guys to think biologically what is happening and then start to treatment plan cases. Having said that, I thank all of you for being here, being a part of this course. I hope the course was informative to you guys. And I apologize if I missed some things, but given the time that I had, there is so much material to cover. And maybe Dr. Zahelka would, maybe in future he wants to organize other courses similar to this one so that I can cover more bases for you and we can discuss more cases. And whenever you guys have an opportunity, come and see us. We are in upstate New York. We have the Institute, New York Implant Institute. I'm the director of New York Implant Institute, and we run a lot of courses here. We do a lot of live surgery courses and so on and so forth. Visit our website. If you have any questions, email me, call me, and I'll be happy to answer. So now I've got about 15 minutes to answer any questions. And do we have any questions?
What about provisionals?
So one of the questions that has been asked is, what about provisionals of soft tissue management? Yes, you should be doing provisional, but this course is not taking that into account, so I did not show you any provisionals restorations. Number two question is, if I have 3 adjacent implants, which better to do, single separate crowns or unite them? Well, if it is in a non-aesthetic zone, I would say just splint them. If you're doing it for the first time, this is your first case, probably splint them. When we are doing these cases in anterior region, we like to have better aesthetics. So single tooth restorations will give you better aesthetics. The papilla can be regenerated the way you want it, and you can restore the patient's smile and aesthetics. Any other questions?
No.
I see no more questions. Apparently I did too good or too bad. I don't know. So, well, once again, I thank you guys a whole lot. Apparently there's
There are more here.
more questions coming up. Okay.
1 second. We have
I'm waiting, guys. Don't rush.
What is your maintenance protocol?
What is your maintenance protocol for patients? And what do you do if they do not follow? If they don't follow it and implant fails, well, blame them for it, if they don't follow it. But yes, my protocols are very, very clear. We have a initial discussion with the patient. We have a very lengthy discussion before even starting the case with the patient. And we go over all the steps. I go over what they have to do preoperatively, what they have to do postoperatively. And postoperatively just doesn't mean for a day. What postoperative means throughout the process till the time we have seen the restoration for up to 18 months in function. So we give a lot of instructions to our patients. It is very important.
Second question.
The other question is, thoughts on introducing intraoral scanners and digital workflow for increasing efficiency. What are your experiences with implementing those into the practice? Well, I do have a fully capable office to do digitized dentistry. We do 1-day implants, we do 1-day restorations as well. But let me tell you, they are not that easy. Um, there are a lot of complications, there are a lot of problems associated with it. I see a lot of my esteemed colleagues are doing, and they talk about it. They feel very comfortable doing it. Um, I do almost close to, if not much, over 500 cases a year, or probably more. And I can tell you my personal experience is not that great. I always find that there is some error either in the achieving the cone beam. They are not very accurate. Like I showed you some of the studies, the meta-analysis that I showed you, which clearly tells you that you cannot 100% rely on the cone beams because of the errors in 3 dimension that can take place. The other problem is that getting it into a SEREC or an E4D that you are using to mill the restorations, how accurate that is and when was it calibrated. There are a lot of factors that go into it. So my advice to you is, yes, it is a great thing. I'm pretty sure they're working every day very hard to make it perfect. But according to me, we have not reached perfection yet. So please wait.
Another question. When you place?
When you so here's another question. The question is, when you insert an implant, it should seat at the crest of the ridge or deeper. Well, that's totally up to you, dear. So let's say, for example, if you are doing a full mouth rehabilitation, okay, and you want to make a patient a prosthesis that you want to do, or what you have planned to do is a hybrid prosthesis. So in hybrid prosthesis, you need more length on the abutment side, okay? So a good idea is to go subcrestal. However, if you were doing just simple zirconia crowns, you can leave the implants at the crest. I personally like them to be a little subcrestal because I like to get a nice emergence profile. I like to see my cases after 8, 10, 12 years having a lot of bone around the implant in that platform switch area. So my personal preference is to go subcrestal, but very often when I do zirconia, a cement retained or screw retained restorations, I would just leave them at the crest.
Another question here, the last one.
Another question is, what was your experience like at the Buty University? Oh my God. I can't answer that question. I'm sorry. All right, I'll try to. Well, it was not bad. Okay, let's put it this way. What advice would you give litigation for any new implant practice setup? I'm not quite sure what the question is. What advice would you give? I think you'll have to write this question again. I'm not quite understanding what you're asking me. What advice would you give to a litigation for any new implant? Oh, regarding litigation. Oh, yes. So remember, litigation can, in most states, at least in US and in the state that I practice in, litigation is only done when you have done a gross, when a gross negligence is proved on your behalf. What does it mean? What is gross negligent? That you forgot to do the proper diagnosis, you didn't do any treatment planning, you were not cognizant of the fact that the patient has some underlying medical condition that could affect the final results. But remember, anything that is reversible cannot be brought into the court, okay? And most of the time with simple cases, simple errors here and there, most of the times you are able to get a really good result. Okay, remember that you are able to get good results with a little bit of bone grafting, a little bit of soft tissue grafting here and there. You can manage those things. But till the time you have fully informed the patient, the consent form is there for a reason. If you have fully informed the patient about what they can expect, then don't worry about it. Okay? Don't worry about it.
No more questions.
All right. I guess that's the end of question. There are some more coming, apparently. Are there?
They just saying thanking you.
Oh, well, thanks a lot, guys. So I appreciate your time again. Again, thanks to Alpha Gate for bringing me here, and my good friend, Dr. Zahelka. I thank you for being a part of the course. Yeah, and I hope to see you soon. Take care, guys. Have a great day. And I'm going to stop the course right here.